Most of you, all of you have sat very patiently, and we have a number of individuals that have asked to make statements. And again, I want to make it very clear, maximum of 5 minutes. We've been very tough on our panelists. And you get 5 minutes is maximum, 3 minutes. After 3 minutes, we're going to let you know. And 3 minutes? That's what I said, 3 minutes. Only people from New York can testify, because they're the only one. All right, we're gonna try. We're gonna start with Brenda. So wait, what else didn't I know in terms of doing this thing? She's sitting there with the 3-minute little. I didn't know you could do it with 3 minutes. It's a technology. Does your scope of practice reach that level? All right. So Blenda Cleary, who is a healthcare consultant and is going to discuss. So why don't you come on up? And I'll tell you okay, come on up quickly, because it'll take 3 minutes to move people around. I can just see this.
Good afternoon. It's good to be back in Washington. I'm here to bring you some good news from the North Carolina Action Coalition. One of our shining examples of what can be done with people working together in a state is RIBBON. That stands for Regionally Increasing Baccalaureate Nurses. And RIBBON was initially funded by a Penn grant that Dr. Maggie McClure, known for her magnet fame, and I wrote along with the Jonas Center back in 2008, and piloted in both in urban New York City, Maggie's territory, and in a rural area in western North Carolina. The pilot partnership in North Carolina was Western Carolina University and Asheville-Buncombe Technical Community College. This Western North Carolina ribbon, which was the first, has now been expanded to include 2 additional community colleges. The first ribbon students began in fall 2010 and graduated with BSNs in 2014. Today, under the ongoing leadership and deep gratitude to this one of Polly Johnson, Ribbon has expanded to include regional collaboratives throughout the state. There's a lot of strengths of this model. There's a business case for it done by the Keenan Flagler Business School at University of North Carolina at Chapel Hill. The Nurse Scholars Program financial aid supports this program. We finally come to terms with a core curricular agreement between the community colleges and the universities. The universities actually took a little longer, but that they're in. So while it has been recommended, I looked at the last draft of these programs, recommended that eligibility for licensure is after the completion of a BSN. I know at least in North Carolina, we have a lot of community colleges that would kind of negatively affect our community colleges because they're expected to produce graduates who can pass the licensure exam. But the other part about that, ribbon students are admitted as BSN students, so there's not a lot of attrition. And actually, already being a licensed RN with an associate degree in their senior year has some real benefits, like a longer orientation period, and these hospitals want BSN nurses, so they support these students financially, and a really strong increase in education practice partnerships. When Polly and I spoke to the first graduating class, we were so moved that all the practice partners were at this graduation. And that's what we wanted in nursing, and I think this may enhance it. The other thing I would say, you have to allow for a very specific position, the student success advocate in these programs. Kind of transitioning them has been a really force for making this happen. So I would say that, and then you need recruiters like you always do. For more information on the Ribbon program, growing enrollments, et cetera, go to www.ribn.org. And we're also, I'm done?
Yeah.
Okay, okay. But we're moving in advanced practice, I'll just tell you that.
Thank you so much, and you did it great, and that's very helpful. Thank you. Sheila Melander, who is the president of the National Organization of Nurse Practitioner Faculties, she's going to talk about nurse practitioner education, with respect to residencies and other issues.
Good afternoon. On behalf of the National Organization of Nurse Practitioner Faculties, I'm pleased to offer comments on the Future of Nursing report. As the voice of over 1,700 NP educators and the leader for quality NP education, NOF expresses its continued support for the report. However, we're here today to request that Recommendation 3 not be applied to NPs. We have significant concerns about applying this recommendation to NP graduates, which would contradict the position of NOF and other NP organizations. As your committee evaluates the report, we would strongly urge you to consider the following. Number one, NP graduates are prepared to be fully licensed providers at graduation. Data are not available to support a need for added academic, clinical, or supervisory hours to ensure safe patient care. Requirement or broad promotion of a formal program after graduation is not necessary and would create higher cost and new additional barriers to building the provider workforce. Number two, NP education is experiencing a significant challenge in securing sufficient numbers of clinical sites and preceptors for clinical education. And a proposed postgraduate residency model would only further exacerbate this problem. It would require an extensive residency network to accommodate placement for the 16,972 new NP graduates we had in 2014. We do not dispute the assertion in the report that transition to practice or nurse residency programs can provide NPs with additional management strategies. However, these experiences are additive for extended orientation and are not necessary for entry into practice. NOF believes that resources should be directed to addressing the current problems for NP clinical education and not for postgraduate residencies. We support the allocation of resources to pre-graduation clinical immersion experiences, expansion of clinical education sites, and expanded use of technology to augment clinical experiences. We would like to see incentives for organizations and clinical agencies to provide high-quality clinical experiences, and we also believe that stronger academic practice partnerships will be needed. Number 5, NOF and 4 other NP national organizations released a statement in 2014 in which we collectively denounced the requirement of postgraduate training programs and promoted the term fellowship for such optional programs. Residency is a term used in medicine tied to specialization and is not consistent with the NP educational model. Number 6, the terminology transition to practice has been picked up by challengers to NP authority and introduced in various state legislations in an attempt to implement more control over NPs. The proposed additional regulatory constraints for NPs are an unintended consequence of the report's recommendation. Given this information, we ask your committee to recognize the barriers and significant challenges Recommendation 3 poses for NP clinical education, and we respectfully request that you do not include NPs in the widespread implementation of postgraduate residencies. Thank you.
Thank you very much. Susan Moyer, she was an assistant program director for the Colorado Center for Nursing Excellence. Thank you.
Thank you. Hello, my name is Susan Moyer, and I'm a nurse. I work for the Colorado Center for Nursing Excellence, one of the co-lead organizations for the Action Coalition in Colorado. I appreciate this opportunity to tell you about progress being made towards the IOM Future of Nursing report in Colorado. In the area of advanced practice nursing, Governor Hickenlooper signed a bill on May 16th that will decrease the number of required MD supervised hours advanced practice nurses need to fully practice and acquire prescriptive authority. This is great progress to having APNs work to their full scope of practice and will improve access to health care in the rural parts of our state. Increasing the number of BSN prepared nurses. Since 2010, Colorado has seen a 9% increase in the number of BSN graduates. This translates to about 350 nurses per year. Many of our state-funded nursing colleges have increased their capacity to accommodate more RNs returning to school to obtain a BSN. For example, Metro State University in the heart of Denver had 30 RN to BSN graduates in 2010. They increased that number to 68 graduates in 2014. All state community colleges have dual enrollment agreements with BSN programs, and magnet hospitals in the metro areas are driving the need for BSN prepared nurses. Unfortunately, our BSN rates in our rural areas of the state remain much lower, and that continues to be a challenge for us. Developing nurse leaders. Colorado is working to identify nurses serving on boards and is active in informing interested nurses of open board positions. 130 board positions held by nurses have been identified. These include governor-appointed boards, such as the State Medical Services Board, hospital boards, community-level boards, as well as professional organizations. To build leadership skills in nurse leaders, we have developed workshops for nurse leaders under the age of 40, deans and directors of nursing programs, and nurse leaders in federally qualified health centers who lead interprofessional teams to improve health outcomes for our underserved populations. Increasing diversity in our nursing workforce is another goal of our Action Coalition work. A diversity advisory committee has been formed to develop short and long-term strategies to increase diversity in our nursing workforce. And a mentor program for diverse nursing students has been initiated. We feel progress is being made in Colorado towards the IOM recommendations, and the funding through state implementation program grants from Robert Wood Johnson Foundation and AARP is crucial to our continued progress. Thank you.
Thank you. Ruth Lubick. Ruth is the founder of Developing Families Center.
Correct.
Okay.
Yes. I'm the founder of Families. You going to tell us what today is?
My age?
No.
I'd have to take a moment to introduce my husband of 60 years. Today's our wedding anniversary. Since the publication of the 2010 report with this birth center case study, many positive events have touched midwifery model birth centers. First of one of which was established in 1975, so it's over 40 years before these things happened. In 2012, the launch of the Strong Start Initiative was announced from the Family Health and Birth Center in D.C. by the then Secretary of HHS, Kathleen Sebelius. Subsequently, the American Association of Birth Centers applied for and was awarded $5+ million over a 4-year period to assist 47 freestanding birth centers in 22 states to reach out to Medicaid-eligible women and families. That award is ongoing and doing well. In 2014, an Urban Institute study of the Family Health and Birth Center called Potential Medicaid Cost Savings from Maternity Care Based at a Freestanding Birth Center was published in MMRR. It demonstrated that $11.6 million could be saved on every 10,000 Medicaid births per year. Projected to the millions of U.S. Medicaid-supported births annually, more than $2 billion per year could be saved while simultaneously improving care and outcomes. Then in 2015, the American Congress of Obstetricians and Gynecology and the Society for Maternal Fetal Medicine has had the UK NICE, N-I-C-E. I'm sorry, I don't remember all the meaning of that acronym. But the UK also in 2014, just before the ACOG, published new guidelines for maternal and infant health systems. Birth centers are now included in step number 1, preceding hospital care at 4 levels. 2010 saw 195 centers operating in this country. Today, there are virtually 300 centers in operation. Some birth centers, in seeking relief from high hospital-based malpractice charges, and one year for us it was $300,000 when our budget was $1,500,000, and also the need for medical collaboration, which is at times difficult for the birth center to find, have partnered with a federally qualified health center, even though FQHCs are set up on a medical rather than a midwifery model of care. As a result, issues arose in organization, billing, cost, and staffing, such that of 7 centers attempting such partnerships since 1984, just 3 are operating fully still. The board of directors of the Family Health and Birth Center was seeking that kind of relief. Although nurse midwives in the District of Columbia legally may practice independently, FQHCs do require internal physician supervision, and that has the potential to undermine the midwifery model. When the relationship with an FQHC was established late in 2013, nurse midwife staff attrition occurred, and it chose to cease births in the birth center, directing them to the backup hospital as of July of 2014. Hopefully, with greater understanding of the midwifery model on the part of all concerned, births at the FHBC will begin again soon in-house. Therefore, changes in the FQHC rules are required when applied to accredited birth centers in order to ensure their excellent outcomes, which include reduced disparities, lower medical interventions such as cesarean surgery, and increased successful breastfeeding, client satisfaction, and personal confidence in mothering and fathering. Accreditation is already available from the Commission for Accreditation of Birth Centers. Active support of rules change is needed. Thank you.
Thank you very much. Mary Sue Gorski. Mary Sue Gorski is a consultant for the Center to Champion Nursing in America.
Thank you. Good afternoon. Boy, it's late in the afternoon, isn't it? I get an opportunity to talk a little bit about the successes that we've had at the CCNA, bringing together the Learning Collaborative around the Education Initiative for 80/20. And we started the Center for Champion Nursing in America, CCNA, started in 2007, and it started working on education capacity. And building on this work, when the IOM report was released, we moved directly to the focusing on the 80/20 initiative and academic progression. We started with a series of webinars and face-to-face meetings across the country, gathering experts to really glean what was working out there. We came up with 4 academic progression models. One of those models was the community college baccalaureate model that we talked about earlier today. Another one of those models was the RN to MSN model, which again, we talked about today. 2 other models are shared curriculum and competency-based, and they're models that are founded on community college university partnerships. These are the 4 models that we've been refining over the last 3 or 4 years with this incredible network that's been put together with the Campaign for Action. It's made up of the APIN 9 projects that you've heard about earlier today, 21 projects in the SIP grantees that have been working on this project, 44 action coalitions. We heard from a couple of the action coalitions working on this as well as other things, and 800 in the active learning collaborative. The successes have been pretty amazing in terms of the process measures, as we've all kind of seen. We have a doubling of enrollment in RN to BSN programs, and we see that as a great success, but we certainly have a lot of work still to do. We aren't making the workforce progress quite as rapidly as we'd like to. One of the things we're particularly proud of in the academic progression is our focus on diversity. And we have really put the diversity component infused in everything that we've done. And I really liked actually when Jared mentioned his data, that is 2013 data, that showed that there was 18% of the action coalitions working on diversity. And we know, because we collect data twice a year, that our most recent data shows that 41% are working on diversity. And we take some credit for that in the education initiatives, even though it goes across the board. Another thing that we have identified at this point, because we have this incredible amount of evaluation data that's available to us to guide the work, is that we're not going to make it, right? We're not going to make it to 80-20 using these current models, using the current strategies. We're making great progress, but it's not fast enough. And in conclusion, we have come up with some great new strategies, and one of those Donna Meyer went over in terms of the emerging strategy that these partnerships, community colleges and universities, work together to build a four-year curriculum where the BSN and the RN. Thank you.
Erica. Is Erica here? Erica Mobley? So Erica is the Director of Communication and Development of the Leapfrog Group, which is a group we haven't heard from, which focuses on helping purchasers. So good to thank you for coming.
Thank you. Good afternoon. Thank you very much for the opportunity to be here today and to provide testimony on behalf of the Leapfrog Group. In case any of you are not familiar, Leapfrog is a national organization driving improvements in patient safety and quality in U.S. hospitals with the backing of purchasers nationwide. Since Leapfrog's inception in the year 2000, we've recognized that nurses play a critical role in ensuring a safe environment for care. Leapfrog operates an annual hospital survey that's completed by over 1,500 hospitals from across the country annually. Included in this survey are questions pertaining to hospital compliance with the National Quality Forum's Safe Practices for Better Healthcare, including Safe Practice Number 9, Nursing Workforce. It has been a measure on the Leapfrog Hospital Survey since 2001 and focuses on ensuring adequate and competent nursing staff service and nursing leadership throughout the hospital. In recognition of a growing body of studies highlighting the key role that nurses play in patient safety, back in 2001, Leapfrog announced that it would publicly report on hospitals that have demonstrated nursing excellence on the Leapfrog Hospital Survey by recognizing hospitals that have achieved magnet status. The announcement was made at the AARP Center to Champion Nursing and Coalition meeting. I'd like to quickly share a quote from Leapfrog's president and CEO, Leah Binder, who spoke at the announcement, stating, "With this addition to our annual survey, Leapfrog is recognizing the vital role that nurses play in patient safety and their strong commitment to transparency. As I visit hospitals across the country, I'm constantly finding that the highest performing hospitals have earned the prestigious recognition of Magnet, and nurses are the most vocal supporters of making patient safety and quality information transparent. Our employer members value this designation and its implications for safety and believe hospitals deserve recognition when they achieve it." Hospitals participating in the Leapfrog Hospital Survey that indicate that they have magnet status currently, as determined by the ANCC, automatically earn full credit for Safe Practice 9, Nursing Workforce. Magnet hospitals are designated as such on the public reporting results page of the Leapfrog Hospital Survey. And magnet status and results of the nursing workforce safe practice are also used in selecting our annual Leapfrog top hospitals, as well as used in calculating the hospital safety score, which is Leapfrog's letter grade rating of how safe hospitals are for patients. 15 years after our founding by large employers, Leapfrog remains governed by purchasers and 100% driven by employers and other large purchasers of healthcare benefits. These business executives, though they're all outside of the healthcare industry, recognize the critical role that nurses play in ensuring safe care for their employees and their dependents. In response to purchaser and consumer demand for more data on nursing, last month Leapfrog issued a report on nursing workforce in partnership with Castlight Health. The report found that 2 out of 5 hospitals reporting to Leapfrog did not have all elements in place to comply with the nursing workforce safe practice, indicating that while we have made a lot of progress, there's still a lot of work to be done. Our purchasers are committed to encouraging hospitals to publicly report data on their nursing workforce and ensuring hospitals are engaged in improvements around nursing. We look forward to continuing this work for many years to come.
Thank you.
Thank you.
Very good. Thank you very much. Kristen Jimison. Kristen is the Director of Communications for the Virginia Nurses Association.
And in my spare time, I'm also the project manager for the Virginia Action Coalition, and I am pinch hitting for our co-leads today. The Virginia Action Coalition is an initiative of the Virginia Nurses Foundation, AARP Virginia, and the Virginia Nurses Association. Initiatives to further the future of nursing existed in Virginia prior to the launch of the campaign, but the national campaign based around the Future of Nursing report provided us with a framework for refining our goals and creating actionable and time-sensitive plans for achieving them. And I just wanted to share a couple of highlights on our work since 2011. In 2012, we worked with the Medical Society of Virginia to create and provide educational resources on the value of nurse practitioners and the related issues surrounding access to care in our state. That year, House Bill 346 passed in Virginia, which removed direct supervision of nurse practitioners and provided them with the freedom to practice in team-based models. And these regulations were promulgated in 2013. We completed a qualitative institutional review board research study with Virginia Commonwealth University on the barriers frontline nurses experience related to scope of practice, and we are working on a white paper that should be coming forward soon. Our 40 Under 40 Emerging Nurse Leader program has provided us with a pipeline of emerging nurse leaders, and we use this program to plan our leadership summit every year, which focuses on providing nurses with the leadership skills required to be leaders not only at work but at the board level. And the percentage of nurses on hospital boards in Virginia is now above the national average. And our state has benefited greatly from funds associated with the State Implementation Program through Robert Wood Johnson Foundation. Sorry, I'm losing my voice. Our grant projects focus on academic progression and interprofessional collaboration. We work extensively on increasing the percentage of baccalaureate-prepared nurses, and our number has risen from 49% to 53%. We feel that in the next 3 years, this number will increase at an accelerated rate. We launched 2 pilot programs for seamless academic progression, which have resulted in new articulation agreements, more nurses in BSN programs, and the conversion of the last entry-level diploma program in Virginia to a new associate degree program, and those are ongoing right now in our state. And finally, we are launching the second phase of an interprofessional team-based care model with the Medical Society of Virginia and the Virginia Hospital and Healthcare Foundation, which is very exciting. So we have a lot going on in Virginia, and we are looking forward to the future.
Very good.
Thank you.
So much. Francie Hollerman. Francie is the Board of Directors Chair-elect of the American Holistic Nurses Credentialing Corporation. Sounds impressive.
Thank you, Dr. Altman. Good morning, or good afternoon, rather. It's been a long day. I want to express my thanks to the Campaign for Action and all it's done to improve health care through nursing and to tear down silos among providers. Having done that in a former position, I know how difficult that is. I think the last panel, the question was raised, what else can we do? So I'd like to address that. As the campaign continues its next wave of work, I'd like to bring attention to one of the Future of Nursing report goals, recommendation number 7, that nurses lead change to advance health. And I know Dr. Altman said in the beginning that the goals that are already established, they're not really open to change, but perhaps the indicators for leadership may be open to consider the following. To date, 7 out of 10 deaths in the U.S. are caused by preventable chronic diseases. The human and financial costs are great, and a paradigm shift must occur to address the situation. If we prepare nurses to step into leadership positions, but do not expand the healthcare paradigm in which they are leading, they will not be as effective as they could be in changing this trajectory of illness. Our choice point is to continue to better manage and detect disease or to adopt an inclusive model that equips RNs with evidence-based strategies to keep people well, where every healthcare encounter is an opportunity to promote health.
Health reform leaders have noted that disease prevention is parallel to, but distinctly different than, health promotion. Senator Tom Harkin of Iowa, who recently retired, was a proponent of providers who wanted to shift our current disease management model of healthcare to an inclusive one that also truly promotes health and wellness. He accurately noted that the screening, surveillance, and prophylaxis for disease require different skills than health promotion. And some of these include things like strength-based approaches like motivational interviewing and appreciative inquiry, which are evidence-based. In March of this year, Senator Harkin recognized board-certified holistic nurses as being at the forefront of leading health promotion and wellness and partnering with others to transform healthcare in the U.S. to a true wellness society. However, our mission as a specialty credentialing organization is not limited to leading health promotion or creating health experts, but seeks to create a culture where all RNs have the knowledge, skills, attitudes, or KSAs, to confidently promote health as well as detect and manage illness. We believe this important issue involves further discussion of how we can work together to engage partners in education, accreditation, and even those who may not recognize themselves as stakeholders in health promotion, such as NCLEX. By embedding the KSAs of true health promotion and nursing curricula and State Board of Nursing exam questions, our future nurse leaders will actually lead from an inclusive model that embraces both disease management and evidence-based promotion strategies. How much, do I have a little bit more time? Okay.
Half a minute.
To provide some background, in 2006, the ANA endorsed holistic nursing as a dedicated specialty supported by research, theory, and scope of standards. Core values include nurse self-care and evidence-based self-reflective practices that fortify the nurse with resilience and promote health on all levels, physically, emotionally, spiritually, and socially. The board certification tests for over 150 competencies and are related to health promotion, wellness, and improve the patient care experience. This is particularly important because the National Institute of Occupational Health and Safety, CDC, Joint Commission, and others have found that health and well-being of the nurse is intimately tied to clinical patient outcomes. It is also relevant because all RNs must first understand and know the evidence and components of self-care, resilience, and health to truly engage patients in their own adoption of these practices and strategies. Thank you so much. Thanks for this opportunity.
Thank you very much. Okay. So Susan Cosman. Susan is the Chief Nursing Officer at Aetna, so we have another payer. That's great.
I think you've met both of us today, all of the chief nursing officers.
Very exclusive club.
It is very exclusive. Good afternoon, and I'm very appreciative to the committee for the opportunity to provide comments to this. And I'm going to provide it from two lenses, as the CNO from a large health plan servicing 23 million healthcare consumers and a workforce of almost 4,000 nurses, as well as someone who's been engaged at the national and local level in the Action Coalition activities. As you've heard today, we've all heard today, there have been many successes that are positively attributing to the accessible, affordable, and quality care for American healthcare consumers. Still, there are many areas of ongoing opportunity that would continue to benefit from the leadership and organizing structure provided by the Center to Champion Nursing. And two specific areas that I would like to focus on are education progression and scope of practice. According to the CDC, and we did not set this up, by the way, the last speaker and myself, about 85% of the annual health care spend for individuals is for individuals with chronic diseases. A well-educated, technologically competent workforce is a necessary asset to develop, deploy, and advance population health to prevent, ideally, but at a minimum, better manage chronic disease. Care delivered by all providers, including nurses and nurse practitioners who consistently improve their skills and work at the top of their licensure, expands this necessary workforce asset and delivers accessible, high-quality, affordable care. To allow nurses and the care delivery system to evolve, a continued focus on education progression is required. As with many healthcare professions, many new entrants are needed to join the workforce to meet current needs and replace retiring resources, which we didn't talk about too much today. Educational advancement of resources within the workplace is an imperative. Changing health delivery landscape requires practitioners in all settings to adapt to technological, economic, and clinical trends, and seamless progression and providing lifelong learning opportunities will positively contribute to advancing health and health care. Scope of practice presents unique and different challenges to this effort. Since the campaign began, we heard today about a lot of advancement in states removing scope of practice or at least introducing legislation to do so. The lack of consistency, however, of regulatory requirements is difficult to navigate state by state, especially for an entity such as us that practices at the national level. Some health plans, such as Aetna, have recognized and credentialed nurse practitioners in accordance with state regulations, but again, it's difficult when they are all very different. This environment creates barriers to care for both local and national populations. Advances such as telemedicine and the mobility of the U.S. population in general beg that to be consistent. A number of states, including California, Kentucky, New Jersey, and Minnesota, are examining the economic case for practice at the top of licensure. This is important work that needs to continue as consumers take on more of the cost of their own care. My recommendation would be to continue the work through the Center of Champion Nursing because they provide key support to states and leadership at the national level to facilitate organization and change at state levels. I would encourage you, though, to be more inclusive in the dialogue with employers and consumers who bear a huge part of the cost of care.
Thank you
And
so
thank
much.
you for the opportunity.
Linda McIntyre. Linda is the chief nurse of the American Red Cross. Very good.
Thank you for the opportunity to participate today. I'll begin with the Red Cross mission. The American Red Cross prevents and alleviates human suffering in the face of emergencies by mobilizing the power of volunteers and the generosity of donors. Upon release of the IOM report on the future of nursing, the Red Cross underwent an exercise to address the key messages of the report with Red Cross operations. The Red Cross Chief Nurse initiatives are aligned under 4 of the Institute of Medicine Future of Nursing goals. The Future of Nursing goals provided the impetus to remove scope of practice barriers for Red Cross nurses engaged in disaster health services. As a result, an RN-led model was implemented whereby registered nurses can practice according to their license and training in responding to the needs of individuals and families impacted by disasters and public health emergencies. The American Red Cross supported the Federal Nursing Service Council's letter to the National Council of State Boards of Nursing, offering, quote, its full endorsement and support for the consensus model for advanced practice registered nurse regulation, licensure, accreditation, certification, and education. The goal is to prepare and enable nurses to lead change to advance health and engage in lifelong learning were also addressed. Volunteer senior consultants and a director of the Red Cross Nursing Network were appointed to provide a stronger framework for nurses and other health professionals to work across the 5 Red Cross business lines, which include biomedical services, disaster cycle services, international services, preparedness, health and safety services, and service to the armed forces. The Red Cross National Nursing Committee unanimously supported academic service learning as the primary focus for engaging nurses and other health professionals in the coming year. This will strengthen the engagement of students in Red Cross programs and services across the business lines of service. Nursing clinical site placement is often a challenge for nursing programs, and the Red Cross can assist by providing opportunities for community health nursing and leadership courses. The Future of Nursing report has served as an important blueprint for guiding our work, which will enhance the value to society now and into the future. Challenges to implementing the recommendations include organizational understanding of nursing practice beyond traditional healthcare systems. It remains a challenge. Viewing health as the delivery of health care versus an ecologic or culture of health model can limit the scope of engagement of nurses in leadership, community, and non-traditional roles. Potential solutions: increase messaging regarding transferable skills and expertise of nurses. Promote translational research such as the David Old study that demonstrates registered nurse impact on long-term benefits of improved quality of life and decreased expenditure. Explore terms and messaging regarding health as an essential component for well-being and sustainable, resilient communities. Continue to find ways to eliminate barriers, including legislative, regulatory, and organizational, that prevent all nurses, including advanced practice nurses, from practicing to the top of their education and training. Increase interprofessional opportunities for health professionals, both in academic and practice settings, with the purpose of better serving individuals, families, and communities. Thank you.
Thank you very much. Very good. Tara Kozlov, Tara is the Deputy Director of the Office of Policy Planning at the Federal Trade Commission. Thank you for coming.
I'm from New York originally. Does that mean I get extra
Yes.
time? Yeah.
No, it means you can get more words in for the same amount of time.
I can talk faster? Yeah,
Yes.
exactly. Thank you all very much for the opportunity to speak today to highlight the FTC's longstanding program of competition advocacy regarding nursing scope of practice issues and the continued influence of the IOM Future of Nursing report. I appear today in my individual capacity as an FTC staff member and manager of our scope of practice work. My comments may not represent the views of the Commission or any individual commissioner. The FTC has been engaged in scope of practice competition advocacy since at least 1985, well before the Future of Nursing report was issued. But that report both endorsed and energized our work in this important area. It noted our long history of promoting competition in healthcare markets and specifically exhorted the FTC to continue its competition advocacy efforts regarding unduly restrictive state laws and regulations on APRN scope of practice. FTC staff took that charge to heart. Since January 2011, we have issued 11 scope of practice advocacy comments. They all cite the Future of Nursing report for its substantive recommendations and also to bolster the FTC's credibility as an advocate. In March 2014, FTC staff issued a major policy paper, Competition and the Regulation of APRNs, which also cites the IOM report extensively. The paper both synthesizes and expands upon our prior state-level advocacy comments with a deeper analysis of relevant economic and clinical research. In particular, the paper focuses on physician supervision requirements imposed on APRNs in many states. In simplest form, these requirements raise competition concerns because they effectively give one group of healthcare professionals, doctors, the ability to restrict access to the market by another competing group of healthcare professionals, nurses. When restrictions are overbroad, they deprive healthcare consumers of the benefits of vigorous competition. Often there are no legitimate health and safety justifications for these restrictions, so we urge state legislators to be cautious when evaluating scope of practice limitations. In addition to published clinical evidence, we point to our nation's own natural experiment, whereby APRNs with full practice authority provide safe and effective care in many states, leading to expanded access, increased innovation in team-based care delivery, and a greater range of choices for healthcare consumers, often with more convenience and at a lower cost. In short, we agree with the IOM and other expert bodies. Expanded APRN scope of practice is good for competition and for American consumers. Finally, we are always looking for new ways to tackle healthcare competition issues, consistent with and building on the recommendations in the Future of Nursing report. We recently expanded our competition advocacy beyond APRNs to include the emerging analogous dental therapy profession. And at a major FTC healthcare workshop last March, one entire panel was devoted to the legal and economic framework of occupational licensure. In sum, the IOM's Future of Nursing report continues to inspire and support the FTC's competition advocacy work on scope of practice. We appreciate the committee's efforts to evaluate the report's impact, and we remain available if you need further information. Thank you.
Wonderful. Thank you so much. Don't go away. I need to talk to you. Frank Purcell, American Association of Nurse Anesthetists.
Good afternoon, Dr. Altman, Dr. Stith-Butler, members of the committee, members of the public. A lot of today we have talked about primary care, coordinated care delivery. We've talked about a wide range of interesting competition. We also have had the opportunity to talk about 60 years of wedded bliss, I think at one point, which was tremendous to hear about. I'd like to talk on behalf of the American Association of Nurse Anesthetists about issues in relation to procedures in healthcare delivery. CRNAs amount to approximately 48,000 in number in the United States, deliver 37 million anesthetics, provide the full range of anesthesia care and chronic pain management services. And in this light, we serve as colleagues and competitors with anesthesiologists. We serve as colleagues with nurses, physicians, and servants to patients who depend on our service for the care they get. In addressing the issue of the Institute of Medicine report on the future of nursing, I'd like to describe a little bit about what has occurred in our field and then what we see coming forward. Because in the field of nurse anesthesia, a good deal has occurred. We have seen advancements in reimbursement and recognition that promote competition and choice and patient safety. Medicare has recognized the full scope of practice of nurse anesthetist services, including chronic pain management by rule. Medicare has recognized that hospital staff, medical staff, should include advanced practice registered nurses. Does not make that a mandate, but it does make that a possibility in hospitals and their governing staffs. Commercial health plans increasingly recognize the work of advanced practice nurses, including CRNAs, most notably over the past few years, growth and recognition by the California Blue Shield system, by United Healthcare, by Aetna, and by our friends as well at Cigna. Perhaps the most dramatic act of the past year or so has been in Congress adopting the Medicare Access and CHIP Reauthorization Act, permanently repealing the Medicare Sustainable Growth Rate Program, but also instituting substantial and major change in how Medicare and other health plans will pay for services and pay for promoting quality. Other aspects of healthcare policy that have seen significant advancements were described by my friend Tara Kozlov at the Federal Trade Commission, also by the U.S. Supreme Court in its North Carolina Board of Dental Examiners ruling, which constrains medical and other healthcare boards from getting outside their lane and impairing competition. Full recognition of nurse anesthetists also in states has been promulgated in several states, including most recently Rhode Island and Minnesota, and eliminating Medicare supervision requirements in the states of California and Kentucky, totaling 17. Within the profession of nurse anesthesia, the AANA and its accrediting bodies have also worked to advance educational practices and standards, certification and recertification in pain in a wide variety of fields. To do, however, in the field federally, we see the current crucible is in two areas. One is in the U.S. Department of Veterans Affairs, seeking to recognize the full practice authority of APRNs to serve our veterans, to eliminate and reduce waits that our veterans suffer from, and to make healthcare work more cost efficiently. There's a lot to be said about that. Further, in the implementation of the Medicare Access and CHIP Reauthorization Act, transition of payment policy from current pay for volume under Part B to payment systems that reward quality and outcomes, that connect and consolidate current quality reporting programs into the merit-based incentive payment models and alternative payment models, require and demand advanced practice nurses and their advocates a seat at the table to be full participants in that work. Thank you very much.
Thank you. That's wonderful. I hope we got everyone on the list. These were great. I think without exception, I think you've added greatly to our deliberations. So thank everyone. Let's see, are we now adjourned? The boss says we're adjourned. We're adjourned.